Okay, everyone, we're going to discuss the management of a patient after intubation. Now, this kind of goes along with the post-ROSC care module, but of course, not every patient that we transport who's intubated is post-arrest. So, the objectives of this module are to describe how good post-intubation management can decrease mortality and improves outcomes. We're going to talk about a few staples or a package of post-intubation management and understand how to determine a RAS score. And we'll talk about the new protocol for analgesia and sedation dosages. So we've got the tube. Now what? We've spent a lot of time talking about, thinking about, and practicing how to get the endotracheal tube, but we don't talk about what to do after that. So here's a package, post-intubation package, and it can serve as sort of a checklist to go through for every post-intubation patient. You can use it on every interfacility transfer of a mechanically ventilated patient. It would just be something a good mental checklist to go through. So you want to consider analgesia first and then sedation. An analgesia first approach allows you to or lets you administer less sedation. So it's generally preferred because patients who are intubated are in pain, okay, or they're having painful procedures performed on them. So it's really good to ensure that their pain is managed appropriately, and then you don't have to give as much sedation, which can have other deleterious effects on them, such as lowering their blood pressure. You want to secure the endotracheal tube, but not only secure it, but you want to check the cuff pressure. You want to use continuous waveform end-tidal CO2, and you want to check the depth. You want to target a sedation score of -2 to 0, and we'll talk about what this sedation score is. You want to use protective lung ventilator strategy, so ensuring that you're not delivering too much volume. Head of bed elevated 30 degrees if possible. So for almost every intubated patient, you want to elevate the head of the bed 30 degrees. Not only does that help improve oxygenation, but it also decreases the risk of aspiration or even aspirating microparticles. And just because they're intubated doesn't mean that you're finished treating them, because there was a reason that they were intubated, and we have to consider what that reason was and continue the treatment. You need to check ET tube depth. So in general, it's 21 centimeters for female, 23 for males. That may vary. And for pediatrics, you can just multiply the ET tube size by 3. Always have a BVM and PEEP valve at bedside. In fact, I think it's probably good to take in all of your equipment that you would for every call when you're transporting a mechanically ventilated or post-intubation patient. So a RAS score is something that we use to determine the patient's wakefulness while being intubated. We want to target a RAS score of -2 to 0. And that is just where they're lightly sedated, they briefly wake to eye contact, and we don't want them to be fully alert. We don't want them to be restless. We don't want them to be agitated. Now, this is very difficult to do. So if you have a patient pre-hospital who is intubated, mechanically ventilated, I would always shoot for a deeper RAS score, being unarousable, than I would a higher RAS score. The problem is that in the ICU, they definitely don't want a very deep RAS score, because that means the patient's going to have more delirium in the ICU. They're going to be on the ventilator more days. But for us, We would prefer a deeper RASS score as opposed to a higher one. If you had to do one or the other, it's always best to be right about here so that the patient isn't in a complete coma. Now, they might be in a complete coma and be unarousable as a result of their condition, but the goal here is that you have a universal way of describing the patient's agitation. So you can describe this in your patient care report, and you can describe this to other clinicians as well. So being intubated is traumatic and painful. We have our own analgesia and sedation package, but if the hospital has them on one that is working, then you can also use that. But it would be good to get orders from the physician before doing that. Now, paralytics are not sedatives. Okay, they provide no sedation whatsoever. Frequently, in the hospital, they administer a long-acting paralytic, such as fake uronium or rock uronium, which can, paralyze the patient for 30 minutes or more, and they administer short-acting sedatives. So it's very possible that when you get called out to transfer a patient, they will be paralyzed but not adequately sedated. So signs of this would be patients that are lacrimating. They look uncomfortable. Patients can still cry when they are paralyzed. All right, but the ongoing administration of paralytics is no longer considered acceptable. Okay, we need to sedate and provide analgesia, not paralysis. If you have a hypotensive trauma patient, then they usually, hypotensive patients in general require less sedation and analgesia. So you can start at the lower range of your doses and titrate up. Fentanyl is always good if you have a hypotensive patient, and that's another reason that it's a good strategy to administer first, because it has less histamine released than morphine, so it's got a good hemodynamic profile. You can give it to a patient with a marginal blood pressure as long as you're not giving large doses, and expect it not to dramatically decrease the blood pressure. And you can always consider requesting orders for ketamine. Now, we know that ketamine is less likely than almost anything else to lower the blood pressure. But if the patient is a peri-arrest trauma patient, anything you give can lower the blood pressure, but ketamine will do it less often than anything else that we have. Hypotensive medical patients, we want to resuscitate them. So a patient having a low blood pressure is rarely, if ever, a good excuse for not properly sedating or providing analgesia. Resuscitate them, give them fluid, add pressors if needed, and then comfort them. Provide sedation and analgesia. So here's our post-intubation medications. So you have Versed. The dose is 0.05 to 0.1 milligrams per kg. Max of 5 initially. You can repeat that, though, every 5 minutes. It's always good if the blood pressure is marginal to start off with the lower end, but if the blood pressure is high, then it's okay to go to the high end. Fentanyl, large doses can rarely cause chest wall rigidity. I'm sure you probably heard this. If you're pushing a few hundred mics at once and you push it rapidly, it can cause chest wall rigidity. So it's got a rapid onset, but it's got a fairly short duration. So if you're transporting the patient more than 15 minutes, you're going to have to redose this. You could also have to redose Versed. So you need to prepare for that. The dose of fentanyl is a little bit different than our pain dose. It is 1 to 2 mics per kg IV, and you can repeat that every 15 to 20 minutes PRN. You want to administer that over about a minute or two, so you don't want to push it too fast so you don't cause chest wall rigidity. Peak effects, this is very important to consider. If I administer IV fentanyl, I could get peak effects within 2 minutes. So if I've got a patient that's uncomfortable and agitated on a ventilator, which one would you want to administer first? Well, you could go either way with this, since fentanyl's going to work faster. I might want to get that on board if the patient's really uncomfortable, if they're writhing around on the stretcher, if they're lacrimating, if their hands are in restraints and they're pulling against the restraints, and I really need to provide some comfort to this patient quickly, I may get some fentanyl. Okay. And then if I administer fentanyl, then I'm not going to have to administer as much Versed, because the two are synergistic. And if I administer fentanyl, which has a better hemodynamic profile than Versed, then I won't have to administer as much Versed and risk dropping that blood pressure. We need to try to evaluate the ET tube cuff pressure. Okay, the ideal ET tube cuff pressure is 20 to 30 centimeters of water. The real risk there is that you can actually cause tracheal inflammation, but not just inflammation, but also ischemia. And then if it's not inflated enough, then the patient can aspirate. And it doesn't have to be underinflated a whole lot, because these microparticles from the gut can enter into the lungs. There are various methods for evaluating ET tube cuff pressure. The best way is probably using an actual device that's made for that, but we don't have that device. There are other ways to evaluate this that are actually accepted in the medical community. And one is to listen for an audible cuff leak. So listen and see if you hear a leak around the cuff when breaths are delivered. But your ventilator is also going to tell you if there is a leak. So you can check for a V leak, and this is very sensitive. So if you have a V leak, first thing you should do is inflate the cuff until you lose that leak. Always check your pilot balloon. So if, let's say that this pilot balloon is intact here, right, and you can feel it, and if the pilot balloon is not inflated, and then you inflate it, but then it deflates, what could that be? Well, it could be that the actual ET tube cuff is damaged, and anytime you deflate it, it just goes nowhere, or it leaks. What do you do if the actual pilot balloon becomes damaged, or it becomes cut, which this does happen? I've had it happen. Instead of you would think that you would just have to exchange the tube, right? You can exchange the tube using a bougie or something like that. But really, we want to keep from having to extubate the patient and reintubate unless we absolutely have to. But there is a way, a nifty little trick that you can use to reinflate the ET tube cuff when the pilot balloon is damaged. So you can cut right below this pilot balloon. You can insert a 22 gauge IV catheter firmly into this tube here, and then you can inflate that with some air like you normally would, and then you could just clamp that off right there. All right, that's just a neat little trick that you can use. Always check ET tube depth. Now this varies based on the height, but we talked about the average depth. You know that if the ET tube only has this much sticking out, okay, if it's just got a little bit sticking out of the mouth, there's a very good chance that it is a right main stem intubation. There have been a lot of ED patients and a lot of EMS patients that have been intubated that have been hypotensive, hypoxic, and then when they get to another facility or when they get to the hospital, they realize that it's a right mainstem intubation. So check your ET tube markings and check your depth, and also take for breath sounds to make sure it's not right mainstem. You also don't want to decompress a patient because you heard decreased breath sounds and then find out that it's a right mainstem intubation. Always secure your ET tube firmly and continuously monitor the patient. Now, when you're transporting a ventilator patient, you have a lot of different attachments. And all of these attachments are just going to end up pulling the ET tube down, right? And they're going to be tugging on the endotracheal tube. And it's very difficult to secure this. Now, here is one method of security. There's like this bungee tie type thing there that they have on each side, and then it goes up and it just keeps it firmly positioned, and it pulls on that and not on the endotracheal tube. For pediatrics, you'll see a lot of pictures of people placing large towel rows on their chest to help support all of these attachments. But whatever you use, you just want to make sure that it's not tugging on the endotracheal tube. And you want your commercial tube holder device to be firmly but not too firmly anchoring the tube down. So in summary, being intubated is painful and frightening. Provide analgesia and sedation. Always monitor end-tidal CO2, every tube, every time. Document their sedation score, obtain their sedation score, and frequently document it. And just because there's a piece of plastic in the mouth doesn't mean treatment is finished. Okay, they may be intubated for respiratory failure because of pulmonary edema, or respiratory failure because of COPD or asthma, or any number of causes. Okay, rarely is a patient intubated just for airway protection. So make sure you're continuing to treat the underlying cause. And that's all for now, and thank you for watching this module.